Yet another interesting case of diabetic retinopathy. A patient woke up one fine morning and suddenly experienced a distorted vision and spots in front of her eyes. The patient went to ophthalmologist and has been diagnosed to have proliferative diabetic retinopathy. She has come to you for your opinion on treatment of her eye. So as I already explained, a diabetic patient, either they will come with the symptoms or they might not have any symptoms when they visit your OPD. If they at all have symptoms, either they will approach you first and you will refer them to the ophthalmologist, or the patient will straight away go to ophthalmologist for their routine eye checkup. Then they might be advised dilated fundoscopy for advanced retinoscopy to check the condition of retina. Then this diagnostic report is being given by the ophthalmologist. Some patients will directly come with the diagnosis report, like we have seen in the previous case, or the patient will like to ask you for the treatment options depending on the condition they have been diagnosed with. So let us have the option in the next slide. So in this patient who has been came with the diagnosis report of proliferative diabetic retinopathy, what would be your recommendations? Option A, control blood sugar, check for blood pressure and lipid parameters. Option B, review with ophthalmologist after 3 months. Option C, treatment with panretinal photocoagulation and anti-VEGF antibodies. VEGF meaning thereby vascular endothelial growth factor antibodies. Option D, treatment with panretinal photocoagulation, anti-VEGF antibodies, and vitrectomy. Just start typing.
Choose your, yes, we do have options here. Option C by Dr. Nina. Dr. Sarah has also taken option C. Dr. Tanya has given option A. Dr. Bhargavi has given option C. Dr. Nitish has written option D. Dr. Sanjeet has again taken option C. Dr. Harsh has given option C. Then we have Dr. Hitesh given option A. Then one of the doctors had given option D as well. There are two doctors who have taken the option D. Maximum is doctors have taken option C. Dr. Dilip, Dr. Rizwan has given option C. Dr. Priyanka again has chosen the option A. Dr. Chandra has chosen an option A. Dr. Rajni has chosen an option A. Dr. Alekia has chosen option A. Then we do have Dr. Alamgir choosing the option D. Option D by Dr. Ramya.
Unanswered.
So I think there's a mixed answer again. Okay. Maximum has gone with option C and A. There are few who have chosen option D as well.
Okay. So let us wait for another 1 minute. I hope everybody has given the answers already, right?
Yes, doctor. I think we can go forward with the explanation.
Okay. So the correct answer is option C, that is treatment with panretinal photocoagulation and anti-VEGF antibodies. Now, as we have already seen that looking at the condition of the retina, diabetic retinopathy has been classified as non-proliferative and proliferative diabetic retinopathy. Similarly, depending on what the patient has been diagnosed, we have to accordingly set his line of management. If the patient is having non-proliferative diabetic retinopathy, say for example, if he's having mild non-proliferative diabetic retinopathy, you will simply call the patient for a regular follow-up after a period of 6 to 12 months. This we have discussed in the screening part. If the patient comes to you with the report of moderate NPDR, still you will call the patient for regular follow-up after 3 to 6 months. But if the patient is having severe NPDR, or even if the patient is having very severe NPDR, now this we are stressing on non-proliferative diabetic retinopathy, whether severe or very severe, we will first start the patient with early treatment with pan-retinal photocoagulation, and we will put the patients on, we won't put the patient on anti-VEGF antibodies. So this is the difference between the NPDR and PDR. So as I was explaining, if the patient is having severe or very severe NPDR, we will put the patient on early treatment with pan-retinal photocoagulation. And this is because we don't have to wait for the progression of NPDR to PDR. What if this case scenario 3, what if the patient directly comes to you with the report of proliferative diabetic retinopathy? If so, then the main line of management is PRP, or the pan-retinal photocoagulation, along with the anti-VEGF antibodies. As I've already explained, it is anti-vascular endothelial growth factor antibodies. So this is a line of management if the patient comes to you with the proliferative diabetic retinopathy. So when do we go for vitrectomy, or how we decide whether the patient should go for vitrectomy or not? Because the main symptoms, this patient was already having this distorted visions and black spots in front of her eyes. So these are all the signs of proliferative diabetic retinopathy. It might be vitreous hemorrhage as well. But still, if she's coming with the report of proliferative diabetic retinopathy, my first line of management will be pan-retinal photocoagulation and anti-VEGF antibodies. And if the symptoms still persist in the patient, even after pan-retinal photocoagulation, the patient comes after a few months with the similar symptoms, despite of pan-retinal photocoagulation, then this is a case of advanced diabetic retinopathy. And then we have to go for the last option, that is the vitrectomy. Rest, it is not advised. So this is how, according to, depending on the classification of diabetic retinopathy, we go for the line of management. Am I this much clear with the line of management? Any questions regarding to this?
Any question regarding the line of management, please write it on the chat box. We'll be taking the questions from there. I think we are good to go forward, doctor. Please again explain about vitrectomy indication.
Okay. Any other questions related to this, the vitrectomy?
No, doctor. We just had this question by Dr. Sanjeev. He would like to know a little bit about this.
So as I was explaining, how to manage the patient with non-proliferative diabetic retinopathy, in that I have explained that either we wait for the progression of non-proliferative to proliferative diabetic retinopathy. Now, how we do that? If the patient is not having any symptoms and he is coming to me with the report of NPDR, I won't directly advise for pan-retinal photocoagulation. Okay. So we don't wait for progression. If the patient is having the symptoms along with the diagnosis of NPDR, we straight away put the patient for pan-retinal photocoagulation. But if the patient is having proliferative, now let me answer why vitrectomy is advised. If it is proliferative diabetic retinopathy, in that we first line of management is pan-retinal photocoagulation, and we put the patient on anti-vascular endothelial growth factor antibodies. So first line of management is never vitrectomy. First line of management is pan-retinal photocoagulation, and most of the patient, 80 to 85% patient, find relief and free of symptoms after this pan-retinal photocoagulation and anti-VEGF antibodies. But you have to keep the patient as follow-up. If the patient is once again coming to you, which is very rare chances, but the patient might progress into vitreous hemorrhage stage, in which we have no other option than to do vitrectomy or removal of vitreous humor of the patient. So this is the last line of management where along with the pan-retinal photocoagulation, I would like to add for the vitrectomy.
Dr. Vinay would like to know, if patient had glaucoma and MNDR, which treatment we can choose? Can we go with vitrectomy or with AVGF antibodies?
I would like to ask this doctor, what do you mean by MNDR? Are you trying to say mild non-proliferative or is it moderate?
Doctor, can you specify MNDR? Is it mild or moderate? It is moderate, Dr. Swathi.
Moderate ka I have already explained. You have to make the patient come for a regular follow-up to you over a period of 3 to 6 months. In this 3 to 6 months, you cannot advise anything invasive to the patient, but the main highlight would be on his glycemic control, on his lipid parameters, on his blood pressure. He need to control all this. Lifestyle modifications will be there. You need to check the patient is on which oral hypoglycemic drugs, or the patient is on insulin. You would like to modify the management of the patient, because your first target is the glycemic control when it comes to moderate NPDR. Next, you can also check if the patient is having any accompanying comorbidities, which I have already mentioned. First and most common is the diabetic nephropathy, which is one of the main risk factors for the patient to develop diabetic retinopathy in future. So no, you have to call the patient for regular follow-up and strict glycemic control.
Okay, thank you, doctor. So we do have one more question, that is by Dr. Ramya. Doctor, can you just talk more about anti-VEGF antibodies role in proliferative retinopathy?
Okay. So as we give anti-VEGF, meaning as anti-vascular endothelial growth factor antibodies to this patient, this is because we encounter neovascularization or new vessels on the optic discs. So to accommodate that, we need to give anti-VEGF antibodies. Now, these are of various types. You can just Google it. These have been categorized into some few names I can just recall if it comes to VEGF antibodies. Sorry, I'm not absolutely, it's a bit difficult names. You can just Google the various names of anti-VEGF, as I've already explained to you, why we give anti-VEGF antibodies. This is typically due to the neovascularization seen in proliferative diabetic retinopathy. Any other questions, please?
We have Dr. Ankit here. He would like about HbA1c.
Yes.
Dr. Ankit has given a question about HbA1c.
What he likes to know about, can you please specify his question?
Dr. Ankit, can you write a little bit more about what doubt do you have regarding this? Okay, till that time, we have one more question. Can you give little bit about various drawbacks of using AVGF antibodies, like adverse effects and etc.?
This is all ophthalmology expert questions I'm getting today. Nothing of my diabetic part. Still, I'm trying to cover your queries as much possible. You can just search about details of anti-VEGF antibodies. You can get a couple of names, like there is something like ranibizumab, aflibercept, and there is something like bevacizumab.
Bevacizumab, yes.
So this even you can just Google if you want any details about this anti-VEGF antibodies. Or you can ask the expert ophthalmologist about it. Anything related to diabetes, please.
Are there any questions related to diabetes?
HbA1c, did he come out? Which doctor asked the question, please?
Sorry?
Some doctor asked me about HbA1c, like what he wants to know. Like it's a brief question. I can explain definitely if we are not falling short of time.
So I think he just would like to know about the specific drug. So if we can go forward with the HbA1c, ma'am, because there is only this question. There's nothing
What
specific.
What is the name of the doctor?
Dr. Ankit.
Aniket.
Ankit.
Ankit. Dr. Ankit, like what exactly you want to know about HbA1c? Can you please specify?
Dr. Ankit, I think
I've already covered in my last webinar. It's a brief topic. I can take 5-7 minutes. Anything related to diabetic retinopathy, or else I will cover HbA1c.
We do have Dr. Path here asking about, is it necessary that every diabetic patient will develop retinopathy, irrespective of their glucose control, just due to a duration disease?
So my answer is not necessarily. As I was already telling you that if a diabetic patient comes to you, many factors are dependent on the development of diabetic retinopathy. First is the duration of diabetes. If the patient is having diabetes since 5 or more than 5 years, then he or she is more prone for the development of diabetic retinopathy. Next, if the patient is having high blood pressure, or if the patient is having hyperlipidemia, his lipid parameters are high. Okay, so he is more prone to develop diabetic retinopathy. Then again, other factors like smoking, or if even in pregnancy, we have seen that pregnancy is also directly connected to the development of diabetic retinopathy. Then again, other comorbidities, which I have already mentioned, like first to highlight is the nephropathy, next neuropathy, and cardiovascular diseases. So these are all the risk factors in which the patient can develop into diabetic retinopathy. Not necessarily every diabetic patient will end up into diabetic retinopathy. Am I clear in my explanation?
Yes, doctor. Dr. Mohammed would like to know, do gender play any role in diabetes retinopathy? And I mean, which is more prone, male or female? So is there any study or anything?
Yes, yes. So few studies are done in in some year 2010 or even beyond, I think 2011, some studies have been done in which in US they have found that men are more prone to the development of diabetic retinopathy as compared to the female, but not necessarily it can occur in male or female. But yes, few studies were done, especially not in India, but in which male has more predisposition to diabetic retinopathy than females. Any other question, please?
No, doctor. I think this brings us to the end of the session. So anything else you would like to know by Dr. Swathi, please write it on the chat box. We'll be taking the question now, or else we'll be ending the session for today.